Hello friends, it's Dr. Kazim once again, and today we are going to talk about assessment of a floppy infant. The outlines of today's lecture is that we're going to start with introduction. Then we'll be talking about some of the causes of a floppy or a hypertonic infant. I would be talking about some of the important points that you need to take in history. I will also be talking about some of the important points in physical examinations, and then we'll be talking about investigations. And last but not the least, I will be talking about some clinical pearls when you are doing your clinical practice. Let's start with the introduction. A floppy child is defined as a child who has got a generalized hypotonia. And hypotonia means that the tone in the muscles is reduced, and that is evidenced by an unusual posturing. So the child has got low tone in his muscles. So usually in a very young age, they would be having a frog-like posturing. They would have reduced resistance to passive movement. So normally, because there is some tone in the muscles, when you try to passively move the limbs, you would encounter a little bit of resistance, which we call as normal tone. But in a child who has got hypertonic muscles, you would see that it's very easy to bend their joints, which we call as reduced resistance. And number three is that there would be an increased range of joint movements. It means that normally the joints would be if you try to move their joints, so the range of the movement would be quite larger than the normal range of movements. Now, it's also important that irrespective of whatever would be the cause of hypotonia in such children, remember that emergency treatment always takes the first priority. So, if a child with hypotonia has got airway problems or breathing problems, so as a doctor, that would be your first responsibility to take care of the airways. And you at that time you don't have to worry about the diagnosis, because the actual priority at that time is just the airway breathing followed by circulation. It's also important that you should know that the differentials can be narrowed down depending on whether the child has got central hypotonia or whether he has got peripheral hypotonia. Now, coming down to the causes of hypotonia. Now, as I told you in the earlier slide, that hypotonia can either be because of central reasons, or it could be because of peripheral reasons. The central reasons are reasons somewhere in the brain, while the peripheral reasons could be anywhere in the spinal cord, in the peripheral nerves, at the neuromuscular junctions, or even at the level of the muscles themselves. Now, we'll start with the central causes. Now, the most important preventable cause of a hypertonic child is hypothyroidism. And these days, you can check for hypothyroidism. It is can be detected on the Guthrie test. But nevertheless, I mean, in developing countries, if you suspect hypothyroidism, a simple TSH test is a good screening test to begin with. Some of the other central reasons are chromosomal disorders like Down syndrome, Prader-Willi syndrome, Beckwith-Weidman syndrome, so on and so forth. Metabolic diseases are also responsible as central causes like glycogen storage diseases. They cause widespread problems in different organs, brain being one of them, and that can lead to central hypotonia. And there, to some extent, there could be muscle involvement as well. Different types of cerebral malformations like Arnold-Chiari malformation, Lissencephaly, and there are different types of neuronal migration defects. They can lead to central hypotonia. Intracranial hemorrhage because of any reason can give rise to central hypotonia. Perinatal events like hypoxic ischemic encephalopathy because of a difficult birth or an evolving cerebral palsy can give rise to a hypotonic child. Similarly, infections, congenital infections like the torch infections, even the sepsis, neonatal sepsis can cause central hypotonia. Then some higher spinal cord injuries, which can happen during birth, trauma, they can lead to central hypotonia. And some of the maternal drug usage can also lead to hypotonia, like use of benzodiazepine or opiates by the mom. That can lead to central hypotonia in the child. Now, coming down to peripheral causes can be anywhere from the level of the anterior horn cell in the spinal cord down to the peripheral nerve, down to the neuromuscular junction, and further down to the muscle itself. Now, anterior horn cell disease like spinal muscular atrophy, poliomyelitis in developing world can lead to peripheral hypertonia. Different types of neuropathies, like hereditary neuropathies, can happen in acquired cause like Guillain-Barré syndrome. Then there could be metabolic toxic neuropathies. They can be caused in endocrine disorders. They can be caused because of nutritional deficiency. So there is a wide variety of reasons which can lead to peripheral neuropathies, and all of them they end up in peripheral hypertonia. Neuromuscular junction disorders like myasthenia gravis or botulism can also give rise to peripheral hypertonia. Muscular dystrophies themselves, Becker's Duchenne muscular dystrophies, which are X-linked recessive disorders and occur in males, that can lead to hypertonia in males. Some of the muscle membrane disorders, some of the inflammatory myopathies, which can occur in autoimmune diseases like dermatomyositis, or can also happen in metabolic conditions, and some of the mitochondrial myopathies, they can also cause hypertonia. Fine. Now, as a pediatrician or even as a general practitioner or a family physician, there would be definitely instances where you will come across cases where you will be presented with babies who are reported to be floppy or have got low tone. So it is important that you should be able to take a proper history and then do a physical examination in order to reach a diagnosis. Some of the important points to ask in history whenever you are encountering a hypertonic baby or a hypertonic infant is to ask, when was the hypertonia first noticed? Whether it was present at the time of birth, which simply means that there were either perinatal or antenatal insults, or whether it was something that happened after the births, which might signify acquired defects. You also have to ask whether the onset was acute, whether it was subacute or chronic, because again, acute onset conditions have got different reasons. Some of the subacute can have different reasons, and obviously chronic have got evolved, like for example, developmental regression disorders. They are usually chronic in origin. You also have to ask if there is any developmental regression, like can happen in Rett syndrome in females, metachromatic leukodystrophy, adrenal leukodystrophy, Zellweger, and the list is quite a big one. It's also very important that you take a proper developmental history, asking about the developmental milestones, especially the motor milestone, gross motor and fine motor milestones, to see at which age they were achieved. It is also very important to take a proper antenatal history, and the special points in antenatal history that you need to ask about is whether the mom suffered from poor fetal movements, whether there has been a history of polyhydramnias, because that can happen in congenital myotonic dystrophy, Prader-Willi syndrome. They usually have got this history. Whether there was a history of a breech presentation, which might signify damage to the spinal cord. And you have to ask about maternal drug usage. So if she's especially been using any opiates, benzodiazepines, anxiolytic, these types of drugs. It's also very important to ask about the birth history, especially if there was any trauma because of a difficult labor, whether the child suffered anoxia because of a prolonged labor or because of some problem, neonatal resuscitation, etc., etc. You also have to ask whether there were poor APGAR scores, which usually are associated with poor muscular tone later on because of central nervous system insults. You also need to ask about family history, whether there has been a family history of weakness, whether there has been a family history of neuropathies or myopathies. You also have to ask about consanguinity, because different autosomal recessive conditions, for example, spinal muscular atrophy, Wernicke-Hoffmann syndrome, they usually there is a history of consanguinity in these conditions. You have to ask about previous early deaths or recurrent miscarriages, which usually happens in different types of metabolic conditions. So you have to ask about these things in the history. And also in the history taking, ask about feeding difficulties, any problems with breathing, respiratory effort. So you need to ask about these things. Fine. So moving on to physical examination. Remember, it's an important part of your diagnosis making. So always introduce yourself to the parent and shake their hands. It's very important, because if you feel there is a problem in the handshake, especially if you feel like there's stiff hands in the, especially if you're doing a handshake with a mother, you can think of congenital myotonic dystrophy. It's very important that you observe the baby and see whether there are any active movements, or the child is just lying limp in a frog posture, or whether there are crossed scissoring of the lower limb. So you have to keep, look for any dysmorphic features. Some of the from the conditions are quite obvious just by looking at them, like the characteristic down facies of trisomy 21, or the specific clinical features of Prader-Willi syndrome. These babies usually they are hypotonic, and they have got feeding difficulties to start with, but later on they become quite obese, and then they have got like hyperphagia in later life. Or characteristic features of mucopolysaccharidosis, like coarse features of Hurler and Hunter syndromes with corneal opacities. Similarly, you have to look at the head size, whether there's microcephaly or whether there's macrocephaly, and what's the shape of the skull. Always measure the occipitofrontal circumference. Especially look at the facial features, see if there are X-prime appearance of the child, whether the child seems to be alert, or whether he seems to be obtunded, or has got an altered mental status. Look for any presence of ptosis, see if the eyelids are drooping down, and see if the child is on any NG tube for feeding, or the child is on oxygen supplementation because he has got issues with the breathing. Always open the mouth and look for tongue fasciculations, because tongue fasciculations is a sort of a clear sign that the child has got spinal muscular atrophy. Also in the physical examination, it's important to note at the posturing, as I said earlier, that you have to see if the posturing is frog-like. Usually it happens in spinal muscular atrophy and other types of peripheral hypotonia. Also look at the breathing patterns, whether there is a bell-shaped curve, or whether there is playing of the lower ribs. Now, part of the examination is to actually you have to do what we call as an 180-degree maneuver of the baby. So the baby is lying in the supine position, and then you hold the baby with both of the upper limbs, and you try to pull them up to sit, and you look for any significant head lag. While the child is sitting, you have to see whether the child has got head control, whether the child is able to sit unsupported or not. Normally, I mean, infants should be able to sit with some support by the time they are 5 months of age, 6 months of age, and by 10 months of age they should be sitting without any support. Then try to hold them and see whether they attempt any weight bearing, whether there is any crossing of the legs, which could signify a cerebral palsy. Also hold them by the side of the chest and see if the baby slips through your hand, because the baby is slipping through your hand, that means significant peripheral hypotonia. And then finally you do what we call as ventral suspension and see if the baby has got what we call as an inverted U sign. An inverted U sign simply means that the baby's upper limb and lower limbs are hanging down, and he has got no tone. And finally you put the baby in prone position, and depending on the age of the baby, see if the upper limbs are extended or not, or if the infant is older, whether he's able to crawl or not, if he's in the crawling age. So this way you complete your 180-degree maneuver, and you note down any shortcomings or any things that the baby can't do. Some of the important points to remember while you're doing a full neurological examination to localize the lesion is that in case of an upper motor neuron or a lesion or a central cause of hypotonia, the baby would be comparatively less weak. They can either have normal reflexes, or they can have like what we call as hyperreflexia. Planters are usually upgoing, and there is some persistence of primitive reflexes like rooting reflex, stepping reflex, so they would be present beyond the age where they should disappear. In case of peripheral hypotonia, where the lesion is either at somewhere at the level of the lower motor neuron or further down, the baby would be very weak. So they have got very significant hypotonia. The reflexes are usually absent and the planters are usually down going. And then in certain diseases, there are classical patterns. And if you do these examinations repeatedly, or if you see these babies repeatedly, you can easily remember these things. Like, for example, if there is proximal muscle weakness, like the shoulder muscle weakness and the hip muscle weakness, coupled with decreased reflexes and tongue fasciculations, so that is quite characteristic of spinal muscular atrophy, also called Wernicke-Hoffmann syndrome, the type 1. If there is a distal muscular weakness, like if there is muscle weakness of the muscles of hand and feet, coupled with decreased reflexes, and then you also note some sensory deficit, that's quite characteristics of different types of neuropathies. And if there is characteristic facial weakness with oculomotor fatigability, that is quite pathognomonic of myasthenia gravis. Now, coming down to the investigations, before I talk about the algorithms, how to further investigate, especially if you are suspecting either central hypotonia or peripheral hypotonia, remember that if you are suspecting the central causes, there are different types of tests that you can do in order to reach a diagnosis. Like, for example, you can do thyroid function tests, you can do a CT or MRI, you can do karyotyping, genetic review, torch screening, and metabolic screening to see for any underlying metabolic reasons. If you feel like there is a peripheral reason for the hypotonia, you can do CK levels to begin with. You can do electromyography. You can go for a muscle biopsy. You can do nerve conduction studies. You can look for the SMN gene for spinal muscular atrophy, and you can also do the CTG repeats for congenital myotonic dystrophy. Now, having said that, it's very important that if you suspect that there is central hypotonia, and you know the reasons could be many, the most important thing, which is more common than the other causes, is infection or sepsis. So the very first thing and the most easy is to rule out sepsis. So if a child presents with central hypotonia, you can do a partial or a full septic screen to rule out sepsis, and that will include full blood count, LFTs, UNEs, CRP, chest X-ray, etc., etc. They usually present with central hypotonia with encephalopathy. And if you have ruled out sepsis, you can do a CT MRI to find any significant pathology in the brain. If that is clear, then the next step would be to screen for inborn errors of metabolism or look for metabolic conditions. And a good point to start with could be starting with a blood gas, which can show you either acidosis or alkalosis. Most of the inborn errors of metabolism present with the low blood glucose. So there will be hypoglycemia. You can look at the blood and urinary ketone levels, and then further you can check on the blood ammonia levels, amino acid levels, and LFTs. And if the child is exhibiting dysmorphism, then you can do karyotyping to look for chromosomal disorders, or you can do genetic studies to find out the abnormal genes which might be responsible for central hypotonia. So that is how you would try to investigate any child who's got hypotonia where you are suspecting that there is a central reason for hypotonia. And now coming down to the algorithm for investigating peripheral hypotonia. Now remember, the very first important point is to evaluate mother and see whether there is any presence of maternal weakness or not. So you have to look for maternal myotonia. So as I said earlier, that you can start with a handshake and see if the mom has got myotonia or not. So if you feel like the mom has got myotonia, then most probable diagnosis is what we call as congenital myotonic dystrophy, and that you can confirm with a DNA test. DMPK or CTG repeats can be done for the mom and as well as for the baby, which can confirm the diagnosis. But if you don't find any myotonia in mother, then you have to ask whether the mother has got a history of myasthenia gravis or not. So, and if there is a history, it could be either a transient myasthenia gravis in the child, and that can be confirmed by doing the acetylcholine receptor antibodies and doing an adrophonium test. Now, If there is no weakness in the mother, then the first important step is doing a CK level, creatine kinase, and you have to see if the CK levels are massively elevated, then you think of congenital muscular dystrophy, and that can be confirmed with muscular biopsy. And remember, this is not myotonic dystrophy, this is congenital muscular dystrophy. So different type of dystrophies, they've got very high level of creatine kinase, and that could include Duchenne muscular dystrophy, Becker muscular dystrophy, etc., etc. If the CK levels are normal, then you have to do DNA tests. You have to look for SMA, spinal muscular atrophy. So you have to do the SMN gene analysis and see whether it's there. Sometimes you can get a positive test, sometimes the test is uninformative or inconclusive. So in that case, the best next step would be the electromyography and the nerve conduction studies. So they can give you different patterns which are suggestive of myopathies, test results which are suggestive of neuropathies, or there could be results which are consistent with neuromuscular junction defects. And then the further workup is easy. For example, if the EMG and nerve conduction studies are suggestive of myopathies, then most of the time these are congenital myopathies and they can be confirmed with muscular biopsies. If they are suggestive of neuropathies, then after that you can do the nerve conduction velocities, and nerve conduction velocities are usually reduced in different types of neuropathies like hereditary sensory motor neuropathies, Charcot-Marie-Tooth disease, some of the acquired neuropathies. And if the nerve conduction velocities are normal, then sometimes you can think, because sometimes the SMA gene may not be that much conclusive, you can think of spinal muscular atrophy in such cases, and these kids can be sent to a tertiary neurology center for further workup. If the EMG and nerve conduction studies are suggestive of neuromuscular transmission defects, then most of the time these are the transient myasthenia gravis or congenital myasthenic syndromes, which can present with neuromuscular junction defects. So, having discussed the algorithms for central hypotonia and peripheral hypotonia, and telling you how to follow in a systematic manner how to do different tests to reach a diagnosis. Last but not the least, the clinical pearls, which you should always remember, is that the list is quite a big one. But remember, common things come first. So don't forget to rule out sepsis. Don't forget to rule out hypothyroidisms, and that can be done by simple tests. So remember always to rule out them as a first step. Always ensure, irrespective of whatever the reason is, remember your ABCs. So if there is any problem with airways or breathing, that always takes precedence over everything else. The diagnosis comes later. Nobody's interested in the diagnosis in a child who is dying and who's got emergent airway problems, so that takes priority. Always observe for presence of anti-gravity moments. It's very important, because if the anti-gravity moments are present, then remember it's most likely to be secondary to central cause. This means that most probably it's caused by central hypotonia and not peripheral hypotonia, because in peripheral hypotonia you would mostly see that the anti-gravity muscle movements are absent. Always remember to measure the head circumference, because if the child is microcephalic, this mostly points to the central cause. So there could be a form of antenatal insults, torch infections, etc., etc. Always remember to check the parents and take a thorough family history. So these are the important ones you should never miss, and I hope with practice you can master these techniques, and next time if a child with hypotonia comes to you, you can diagnose it very easily by following these algorithms. So thank you very much for listening to this small lecture. Stay safe, stay healthy. Thank you very much. If there are any questions, you can always ask me in the comment section below. Thank you very much.